Morning, everyone. Thank you for coming to the quarter annual Global Grand Rounds. We're just having everyone come into the meeting right now. So we'll just start in a couple minutes, letting everybody in. Um, so we'll just wait tight for just a few more minutes. And if you have any questions, you can write it in the chat. I'll also be posting a survey in the chat if you guys could fill it out at any time, or I could email it to you after. And please do also include your emails in the chat. Thank you so much, and just hold tight, and we're about to start.
She muted you.
Yeah. Dr. Gupta.
Yes, Dr. Oye.
Good morning. Good morning. Okay, we'll get started here. We're time pressed. Thank you again. Go ahead.
Oh, sorry, you have to let people into the meeting. I believe some people are waiting to be let in.
Okay, we'll do that.
If they send a request, we can do that because we don't see any requests right now.
Okay. Some people are saying that waiting for the meeting to start.
That doesn't make really. That doesn't make sense. Usually, it should be a quick connection.
Yeah. And it usually saves like.
Hi, Cynthia. How are you all? Did you have any problems connecting?
No, did not have any problems connecting. And initially, I couldn't hear your room, but then I realized you weren't speaking.
Okay.
Dr. Gupta.
Yeah.
Dr. Gupta, you are co-host of the meeting as well?
Correct.
Yes,
I
ma'am.
urge you to be so that you can also let people in.
I'm not a host on the Zoom platform. I'm just a participant.
Dr. Oye, do you have another host, a co-host? Under participant, you can make somebody a co-host because if your computer is the one where you're making the presentation, you probably don't want it to be the only one that
Reclaim host.
You might even disable the waiting room.
So Dr. Oye is the reclaim host, and Yati can be. If I'm gonna make
it a co-host. Or you can be.
We are like host right now. I made that.
And
then if I do that, then it just shows me like make her host. Like for example.
That's fine.
Yeah. Do you want to change? Okay. Yati is the host.
Yati, you be the host so we can move on because we're going to be busy on the side. We'll switch it to you. Got it?
She's on. Let's see.
Dr. Yati, can you hear me?
Yes, I can hear you, Doctor.
Okay, we'll switch to your host now, so because we have a lot of activities on the side.
Okay.
So so you can be the host, okay?
Yeah. Some people are still not. I'm not getting the requests, and says waiting for host to start the meeting.
Well, others have not had problems joining, so I'm not sure what the problem is today. We've never had this problem before.
Yeah. I'll try to figure this out.
Okay, why don't you do that? We're going to get started here. Okay. Good morning, and thank you for joining the platform today. I'm Dr. Herbert Oye, and it's our pleasure to welcome you to the global. It's our pleasure to welcome to our global. What's that?
You could try again.
Hello, can you hear me now? Okay, can you hear me, Gupta?
Yes.
Okay. Good morning and welcome to our second quarter Global Ground Rounds of 2024. I'm Dr. Herbert Oye, and it's our pleasure to have you here this morning in the U.S. and afternoon or evening in other parts of the world. We're excited that you're here today and you've given us your time to join us on this platform. We'd like to be expedient with the case presentations today. I'd like to take this opportunity also to thank our participating partners in this process, the Zuma Foundation, which has been quite pivotal in ensuring that we have members join and non-members join our platform to provide to be part of this process. The Zuma Foundation is a non-for-profit foundation that has done work in Africa, specifically at this time Gambia and Ghana. And we are quite grateful for their participation and partnership. In addition, we'd like to thank members of the Oye Global Medical Foundation for work related to educational scholarship as well as medical treatment for medical underprivileged communities around the world. And would also like to thank the Global Health Mission, Dr. Olushangode, who is the president of that organization and a very key partner to Global Ground Rounds and endovascular conferences. Would like to also thank the Bielsa Specialist Hospital and the endovascular clinic in Lagos for continued work in promoting endovascular care in the sub-region of West Africa. And also like to thank the Edward B. Dietrich Vascular Society for continued support of our educational programs. Lastly, I'd also like to thank the Raleigh General Hospital, our host institution here in West Virginia, for giving us the opportunity to meet in person in their facility to promote our program. Today, we have some speakers, international speakers and national speakers here in the U.S., and we'll would hopefully learn from them a thing or two. The whole purpose of the Global Ground Rounds is to exchange medical ideas between clinicians or amongst clinicians and non-clinicians, as well as our patients and the lay public. The idea is to let us know of trending technologies in medicine and surgery, and also to let patients know what treatment options are available for them in the medical or surgical realm. So we're excited that if you're a clinician, you may learn about you've learned about a program and hopefully become part of the program. If you're a patient or just a lay member, would also continue to wish you join us in our future programs. We have this program every quarter, and this is the second program for the year. The third one we will be due in sometime in August, and the last one for the year in November. So please look forward to the announcements from Dr. Gupta, who has done a fantastic job in getting the program together. So again, thank you, Dr. Gupta, and thank you all for joining us this morning. At this point, I'll turn the program over to Dr. Gupta for the introductions, and we'll continue.
Good morning, everybody. Thank you so much for joining this meeting, and for all the presenters, thank you for preparing your presentations for us to learn from you. We are so excited to create this community of global knowledge where, you know, it doesn't matter our background, where we're coming from, but we have the same goal to provide the best care to our patients, bring care to rural communities, no matter what country or continent we're in. And we're just so excited to be here with all of you. So I'm going to be sharing in the chat a Google survey from the Uzima Foundation, and just about how you got to know this event, and put your email in. So, you know, when we come to our annual conference later this year in the fall time, we could have, you know, everybody participate and present and bring interesting cases to help everybody learn from. Additionally, during this call, if we could all have our our microphones muted because sometimes it causes some interference during presentations, and then everything can go smoothly. And then, of course, questions are always welcome. And at the end of all the presentations, you are welcome to ask the speakers questions where you can unmute yourself or even raise your hand one at a time and we can call on you. So yeah, just it's informal, just nice place for us all to gather and learn together. And thank you again for all being here. I'll give it over to Dr. Herbert Oye, who I've had the pleasure of being able to learn from as a teacher, as a mentor, who's done amazing work, globally, with limb salvage. And today he'll be presenting on critical limb ischemia. So whenever you're ready, Dr. Oye.
All righty. Thank you, Dr. Gupta. I appreciate it. Sure.
Right now, I can take it.
Yep, just share the screen.
I'm just going to share it as a presentation.
Can you see it, Dr. Gupta?
Yes, we can see it.
Okay.
Okay. Many do you know, where to present? Not like this way.
Full screen. All right. Good morning again, afternoon, evening, wherever you are. And thank you once more for joining us this morning on this platform. I am Dr. Herbert Oye, and I'm very passionate about critical limb ischemia because it's a problem that we face not only in America, rural America, but also around the world. Again, as you'll see during our presentation and from our travels, we've had the opportunity to treat persons from around the world with such bad issues. The incidence of peripheral arterial disease is usually estimated at about 200 million people worldwide. In the United States alone, it's over 12 million recorded Americans affected or more with peripheral arterial disease. The amputation rates in the U.S., it's around 200,000 to 250,000 amputations per year. And the result in primary amputations in medical development development countries can range from 65 to 80% or more. So those are huge numbers when it comes to one losing a limb and one not be able to work, and the psychological effect of losing a limb. When we talk about critical limb ischemia, it commonly affects the legs, but it can also affect the upper extremities. The key factor is atherosclerosis, an advanced calcium buildup, calcification of the arteries. Again, the increased demand for oxygen is lessened when patients have such aggressive condition, and this results in pain when they ambulate or pain at rest in advanced cases. And this can sometimes progress to the point where they develop ulcers or wounds that don't heal, and they progress then to tissue death or gangrene, which is a very, very late stage. Unfortunately, what we normally see in some communities around the world, even in the United States and other parts of the world, is patients present very late in their course. They tend to think that the problem will go away. And in the United States and our communities, they really do present way, way far into the disease process. In some parts of the world, especially in Nigeria, I can tell you categorically, patients will have ischemic problem or advanced limb threatening conditions and will seek the help of a pastor, a priest, or somebody to pray for them when in fact, they do need to have something be done to them medically to reverse the process. Again, the problem with critical limb ischemia is it affects the major arteries, and it could be the aorta, the main pipe that leaves the heart and goes to other parts of the body, or the iliac artery, which is also between the belly button and the hip areas. It could also affect the femoral arteries, which is between the hip and the knees, the popliteal artery, which is at the knee level, and the tibial arteries, which are below the knee. Every normal person with normal arteries typically has three arteries below the knee, two tibial and one peroneal artery. However, we only need one good artery to walk and one good artery to keep our limbs alive. Once all three arteries are diseased severely, or mainly due to calcium buildup, the calcification process, it can lead to sometimes irreversible situation where, if not treated in time with techniques, either open bypass surgery, angioplasty type procedures to improve flow, that person can gradually advance to the point where they may have tissue death and over gangrene and eventually lose the limb. So you will see that as we proceed in the talk today. So the risk factors, again, are common. Sclerosis or plaque buildup within the arteries. It's no different than one having a heart attack from plaque buildup within the arteries of the heart. It's the same process, plaque buildup within the arteries of the lower extremities or the upper extremities. A big major factor we find in patients having critical limb ischemia or peripheral arterial disease, usually high blood pressure, hypertension. And I guess some of our speakers later will talk about hypertension. Smoking is very common in our part of the world, and it's a major issue. Genetics, we can't change who we are, how we were born, but then we certainly can change our lifestyle. Diabetes is a major complaint, and sedentary lifestyle is also not a concern. The other thing that we worry about.
It's still on.
Just 1 second, please.
I'm just going to make sure that she gets the right screen.
Okay.
That's good now.
Are we good? Okay, yeah. In our practice of endovascular surgery, which is a subset of vascular surgery, we use minimal invasive techniques to improve blood flow to the lower extremities or upper extremities to reverse the bad effects of PAD or critical limb ischemia. And open bypass surgery sometimes play a role in some cases when it's severe and the minimum invasive techniques may not be adequate. In our practice, we typically see patients with this condition and have to do some fundamental or basic tests. The most important, apart from the physical examination of the patient to see where they are clinically, is the preoperative CT angiogram, the dye test to kind of evaluate what they have or don't have. If we suspect that they have severe disease of the tibial arteries below the knee as the primary culprit, it's very important that we do what we call a catheterization, where we actually put a catheter within the artery and shoot some dye and really have great detail of the arteries involved, so we can now proffer appropriate management to help them out. When is endovascular therapy for critical limb ischemia necessary? Well, the facts are you have to improve blood flow to the affected area. If it's in the fem-pop area, the thigh to the knee area, we have to provide straight line flow of blood going through those arteries to improve the chances of us not losing our limbs. There has to be a healthy balance between the risk and benefit of prolonged intervention when we do something the amount of dye or contrast we give to treat the patients and the overall medical condition. So if somebody has kidney failure, they're not really on dialysis yet, you don't want to be giving too much contrast because you really send them to dialysis by doing so. We have to avoid any blood clot or plaque escaping from the area of our treatment going downward towards the foot, because that would make the situation worse. We have to look at aggressive intervention to solve problems when that occurs. And when the arteries, again, arteries are mostly involved, that causes to have critical ischemia usually are the tibial arteries, the arteries below the knee. So we have to be able to get good information about those arteries. And how do we treat these patients, or how do we approach them? We can approach them, let's assume that the patient has a problem in the left leg. You can approach them from the right groin, go across from the right groin into the belly, down to the left leg, and treat the problem. You can approach them from the left groin downward. You will sometimes can approach them from the ankle area going upward. So there are several ways you can treat patients. You can also approach them from the arm and go downwards. So those are the ways we manage those patients. Our treatment strategies are multiple. And again, with endovascular surgery, the beauty of endovascular surgery is it's minimally invasive. You don't have to make any cuts, needle, wire, balloon, catheters, and you treat them. And these are some of the options. Plain balloon angioplasty, wire goes through, the special balloon that goes through you over the area in question. You inflate the balloon at some target pressure to crack the plaque and improve flow. Cutting balloons also a special types of balloon that sometimes will be able to crack the plaque because they are very aggressive. And nowadays, technology has been kind. The endovascular technology has been aggressive since the early 90s. And now we have what we call intravascular lithotripsy, which is a shockwave therapy by a company, Shockwave Medical, that actually blasts the plaque and we're able to now improve flow. We've had some in our practice where we're able to do less bypasses and more restoration of flow using this technique, to the point that we're able to, even some patients who have had bypasses before, we're able to go through a native artery and restore flow by using this technique. So it's a useful tool in our clinical armamentarium. At the endarterectomy option, it's where we actually do an open cut and take the plaque from the artery. Sometimes some patients have generous amount of plaque, especially in the groin area or below the knee area. We are able to remove that plaque and restore flow. A hybrid procedure is when you do a limited form of endovascular technique, minimally invasive, and also some portion of open technique, like you can do an endarterectomy on one portion and you do the balloon job on the other, or to improve flow. And open bypass is more debilitating because we actually have to make big cuts, tunnel tubing, or use a patient's vein to go around the area that's clogged up to restore flow to a healthy area of the artery and preserve the limb. But with open surgery, you'll have increased risk for infection because we have cuts and other complications. The basal trial was done, and it looked at the benefit of bypass of artery technique versus angioplasty, which is a balloon technique, in severe cases of ischemia. And the bottom line of that trial was endovascular therapy appears to be equivalent in its success rate compared to open bypass surgery, which we've used for many years. And the limitation, however, was plain balloon angioplasty was only method for endovascular therapy at that time. Nowadays, with the advent of intravascular lithotripsy or the shockwave technique, I'm certain that the percentage or technical failure associated with plain balloon angioplasty will be a whole lot less, because in that study, it was about 20% more technical failure associated with plain balloon angioplasty. Bypass does offer more debilitating conditions, so we also definitely have to keep that in the back of our minds. Let's spin through a few cases to kind of bring the point home. This is a 68-year-old person, female, who's had what we call an aortobifemoral bypass. So she had a bypass connected between the aorta, right below the level of the kidney arteries, to the groin arteries. She had that 15 years ago. And she also did have a bypass done from her left groin to above the knee. Also, she was a smoker and presented with advanced ischemia or lack of blood flow to her lower extremity, and there was indeed no blood flow from a level of the kidney where the bypass was done on one limb all the way to the foot, nothing at all. And she had surgery done to remove blood flow, the blood clots from the bypass and from both bypasses, and we restored flow, but she continued to clot, recurrent clotting, and advanced surgery ways of blood thinning medications, heparin, agathroban, TPA, none of those worked for her. She even had a fasciotomy done, which progressed, and she just got worse. Even though she had flow and she had a palpable pulse in the foot, she presented solely in the process that she technically had what we'll call absolute ischemia. She had a pulse in the foot, but the foot was dead. So ultimately, she had an amputation for pain relief. And this kind of shows you the imagery of some of the of the foot and the leg, and in the person with advanced ischemia. This is what we want to prevent. Sometimes we're successful, sometimes we're not. This is one case that, in spite of all the technologies thrown at this patient, she did not reverse, of course. She had a pulse with this foot. She did have a pulse and an ankle, but it was not enough to keep her foot viable. So that's absolute ischemia. So she unfortunately had to have an amputation. She did well with the amputation. And when we do amputate, we want to make sure that amputation that amputation is done nicely, and the patients have good cushion on the amputation stump, and they're able to get aggressive physical therapy so they can ambulate with the prosthesis within 6 to 8 weeks. That's our goal. We also want to note that before we offer amputation to patients, we have to make sure that they are psychologically ready for it, because some level of depression will accompany an amputation. Somebody's been walking around, all of a sudden you cut their leg off. You don't expect them to be in the best possible mental state. So it's important that they understand that nothing else can be done. And in our practice, we really ensure that there's no way possible for them to have a limb before we consider amputation. That's what we do. So this, unfortunately, was the case with the patient, but she did well. And she is, at this time, ready for a stump shrinker, and she'll begin a prosthesis within the next 2 or 3 weeks. The next case, this is a patient who had previous intervention and had clot in terms of, it's kind of similar to the first case, but the limb of the bypass, again, on the left side was completely clogged up. And she also had a bypass to the knee, which was also clogged up. So we're able to go through the left groin and remove a clot from the aortobifemoral bypass left limb, and we're able to now restore flow. And we had to redo the bypass on the left leg from the groin to the knee. And this is an example of a surgical option again. And this patient, prior to my seeing her, had a colleague do a bypass on the right groin to the left groin. And but when it clotted 24 hours later or so. So when I had her, I then had to go back to the original limb on the left side and remove a clot, then restore the flow and rework the bypass on the left leg with restoration flow. And she did well. And you could see the picture here on the left is the CT angiogram demonstrating what the bronch does have. And the middle picture shows, you can see some stents in the area that are clogged up. That's a native artery. You can see the wire demonstrating going through the left limb of the aortobifemoral bypass after we remove the clot. And you can see the high area of narrowing at the area of bifurcation or divide. We then balloon that area, and you can see the balloon going up that. And we follow that by putting a stent in there. And to stabilize the stent, we put another stent on the opposite side. But she did quite well. The next patient had a CT angiogram, which demonstrated a blockage of the iliac arteries. That's the artery between the belly button and the hips on either side. And also a bypass between the left groin and left thigh was left knee was also occluded or clogged up. And again, we're able to do, in this case, balloon angioplasty of the iliac arteries. And we put stents, bilateral stents in the iliac arteries and restored flow there. And we proceeded then to do, as you can see, the area of blockage on the picture to your right that was treated. We put a stent in there to improve the flow. And you can see the balloon going up, but then went from the left groin from right groin to left groin. Did some balloon angioplasty on the left groin. And when finished, you can see stents in there demonstrating improved flow of the arteries. And again, this patient had a hybrid procedure. She had extensive amount of plaque in the left groin, and that's the picture on the far right. You can see the plaque that was removed from the left femoral artery. That's an example of the atherosclerotic plaque or calcification you see in some patients. The next patient, now moving up to the upper extremity, I did say critical limb ischemia can affect the lower extremity mostly, but sometimes you can have patients that have critical limb ischemia that affects the upper extremity. And this is a case of a lady who had right upper extremity and left upper extremity pain. And the picture here shows blood flow on the far left, where the blue line is, it just stops. That's within the chest area. There's no flow beyond that. And she had been seen by a physician before who attempted to fix her, couldn't. So we went ahead and we approached her by going through the neck, the carotid artery, and went downstream from the carotid. We're able to partially get into the blockage, but we couldn't completely get into the blockage. So we had to go through a groin, and we're able to now cross the blockage. And eventually, and you can see the middle picture and the final pictures to the right, where the problem was solved with balloon angioplasty and stenting. And she presented, this was in January of this year. She presented last week and had the opposite side, left subclavian done also. So this is a nominate artery angioplasty and stenting on the right side, and she did quite well with immediate restoration of flow and palpable pulses in her arm, which indicates that the stent was patent. And that's it again, seeing some of the work. And the balloon going through, you can see the balloon in the middle picture, the stent in the middle picture. I see the stent in the picture to your right, also the balloon on the far left being inflated in the final picture. So again, that's a beautiful demonstration of hybrid procedure where we're able to go through the carotid artery as well as percutaneously to go through groin in the to treat this patient's condition. And this is the same patient seen last week with the left side demonstrating the high blockage in the middle picture, the balloon being inflated, and you could see the area that we treated in January stands to the left of that. There's still paint. This is an interesting case. For this conference, I wanted to present this case because it tells us some of the challenges we face, not only as developing countries, but challenges we face in rural America as well as in Africa. So this patient is a 57-year-old gentleman with diabetes mellitus, presented to actually sent a picture to me in December, a few days before the new year, with complaints of a wound infection, and wanted to have that taken care of. I offered that he be seen by some colleagues in Nigeria who could manage his care, and he indicated that he wanted to come to the U.S. because he had a visa. So he ultimately found himself to Beckley, West Virginia, and upon arrival in the emergency department here at Raleigh General Hospital, was treated with, was immediately treated, and part of his laboratory workup showed some strange findings. Back in Nigeria, he had been studied in Rocephin and gentamicin antibiotics, and when he arrived in Beckley, This is a picture he had before he traveled out and got worse when he got to Beckley. Initial evaluation in Beckley demonstrated, showed that he was able to weight bear, which is a main issue. And he had gangrenous changes with right foot, covering one and one half of the foot. His white count was over 20,000. Hemoglobin A1C was greater than 11, even though his Doppler pulses were normal. And that foot picture you're seeing in Nigeria had progressed to this when he came. So this is really a case of critical ischemia, advanced ischemia, secondary to diabetes mellitus and some level of atherosclerosis, not direct but indirectly because of the inflammatory changes associated with this condition. He did have thrombocytosis. His platelet counts were very elevated, and he was actually clotting the digital arteries to his foot, and that was a contributing factor to his problem. He was treated with amputation of forefoot of the foot via short pass amputation by the foot and ankle surgeon. He would develop worsening pain and occurred skin eschar within 10 days of the additional admission, and he started to develop extreme tachycardia, heart rate in 140s, acutely short of breath, diaphoretic, and oxygen saturation, ABG, was only 42%. And EKG showed non-STEMI. Because of the shortness of breath, I was concerned that he may have had PE given his long travel. Because when he also presented his GFR, his kidney function was only 9%. Again, the VQ scan was negative for PE. Because of his kidney condition, we could not do a CT angiogram because my hurt his kidneys even further. So the VQ scan was done. Because it was getting worse, we proceeded then to do definitive right below knee amputation, which he tolerated quite well and was able to demonstrate some marked improvement. And this then followed with a cardiac catheterization, which demonstrated 5-vessel blockage, and he required 4 stents placed in his heart, coronary arteries. And this is an example of the short burst initial amputation that was still thrombosing from the thrombocytosis that resulted in below knee amputation. So he has done well. Resolution of his pain occurred, but did have sustained a fall. And one of the things that we worry about when we have major amputations, patients sometimes forget they have a missing limb and can just start walking and fall. So he had that situation and had an abrasion of his below knee amputation stump, which was locally treated. He got better. Luckily for him, he was able to avoid going on dialysis. His kidney function returned to normal, even though he had sepsis and all the other things associated with his care. He got better. He did develop acute renal thirst, as stated. GFR was only 9%. Ordinarily, he would be on dialysis. Cut off about 13% for you to go on dialysis. It was at 9%, but with hydration and medical management, removal of medications that potentially hurt his kidney, like gentamicin, did help him out and was able to avoid going on dialysis. Again, the key problem here was that he did have the sepsis. Sepsis-induced inflammation. Inflammation caused the persistent thrombosis from the thrombocytosis of his arteries, but all those got better with treatment. And acute coronary syndrome was a major problem for him. And the gentleman was quite lucky because with all those many vessels that are diseased, he could have really had an unpleasant event in his travels between Africa and the United States. But he's doing well clinically. It's ambulatory, has a prosthesis, and he's doing quite well. Take-home message here: when is amputation necessary? This is a case where a patient had the means to travel out of a country in Africa to seek health care solutions abroad. Medical tourism costs in Nigeria vary from 1.5 to 2 billion US dollars per year. That's a lot. We must therefore improve our healthcare system in developing countries. The structure has to be improved, the training has to be improved, the care of patients has to be improved so we can reverse this costly trend. Given the multitude of problems the patient had, the patient could have had an unpleasant event in his travels. We must therefore do better to improve our healthcare system in Africa. Critical limb ischemia treated with endovascular therapy has a high technical success rate, greater than 90%. lower procedure morbidity less than 2%, complication rates at less than 5%, and 1 to 2 year limb salvage was greater than 80%. With the advent of intravascular lithotripsy and other great balloon technologies, we're certainly will be able to improve our limb salvage rates even from 80% to much higher rates. In conclusion, endovascular therapy has gained popularity and traction for many patients with critical limb ischemia. Some advanced cases of failure can be tackled with open intervention and hybrid procedure. Thank you so much. Any questions?
If you have the patient has allergy to the audience, how you will approach it, and the patient is CTA or something.
Yeah. For a patient, and thank you, Dr. Shangar. That's Dr. Shangar's question is, if a patient does have allergy to the contrast or the dye that we use to do a CT angiogram or similar testing, how do we manage that? Usually, if they have allergy, some people say they have allergy to contrast. It may just be because they skin itch or they have nausea or vomiting. But typically, we pre-treat them if they indicate they have an allergy. Or even if at the time of treatment, they develop an allergy to the contrast, we will immediately treat them with solumedrol. I like to use solumedrol, 125 milligrams for persons that are not diabetic, and 80 if they're diabetic. And Benadryl or diphenhydramine, anywhere from 12.5 milligrams to 25 milligrams, depending on the patient's weight. So that usually works well for most people. In addition to that, we hydrate them with normal saline during the procedure to minimize the contrast issues. And if they're having surgery and supposed to have surgery, we pre-feed them also before this contrast, the exposed to contrast in surgery. And in surgery, we give them additional bicarb and also the solumedrol and the Benadryl. Thank you, doctor. Any further questions?
There's one question in the chat, Dr. Oye, from Dr. Idowu Ifelua.
Okay.
He's saying about the 57-year-old Nigerian with the diabetic foot, what endovascular intervention could have been done at the earliest stage when he sent a picture?
Yes. In this case, he did not have the need for endovascular intervention because his arteries were patent. The only problem was his digital arteries had thrombosed because of the sepsis infection. He did have excessive amount of thrombocytosis, which was causing the digital vessels to thrombose and therefore exposed him to the infection getting worse. He did not have arterial occlusion. But let's assume that he did have a problem that needed to be fixed, either a blockage in the iliac artery, even the aorta, or the tibial arteries. Then in the vascular procedure option, again, this would be a different case because his GFR is only 9. So I definitely would not be doing CT angiogram on him. That would make him worse. Maybe MRA sometimes, but you could certainly take him to surgery and hydrate him adequately. If his renal function were a little better, then you could do catheter-based arteriogram, very minimal contrast, diluted contrast, no more than 10 cc's. Figure out where the problem is. Then you can now decide if endovascular options such as angioplasty would work, intravascular lithotripsy would work, or if he just needs stenting. But in his case, his arteries were all patent. He just had thrombocytosis from the infection.
I believe we have one question from Dr. Finn, who has his hand raised.
Okay.
Yeah. Hi, Dr. Oye. Thank you very much for your presentation. I'm an endocrinologist in Florida. I like your point on the take-home point, but I think that the main thing that Africa is going to need is to prevent the incidence of diabetes and also engage primary care in treating diabetes, because this is a very debilitating disease that will end up with complications that Africa cannot handle. And I think that we should, as for African leaders, they should try and focus on all these fast foods that are coming into the country, lifestyle modification, and also educating the public about diabetes management. But thank you for your presentation.
Thank you, Dr. Payne. I couldn't agree with you anymore. A part of our process in this whole global ground rounds adventure, as well as the endovascular conference we run every year in October, the endovascular conference of Africa and rural America, is that it's essentially looking at the role of lifestyle changes, preventative medicine, as well as curative medicine when necessary. It's important that we control diabetes. It's a major problem. The diabetes and uncontrolled hypertension are major issues that afflict a lot of folks in Africa and globally, of course. And if we can keep our blood pressure controlled, imagine the things we can prevent: strokes, heart attacks, circulation problems, including what I just talked about, ischemia, PAD, just from controlling blood pressure. For all the risk factors associated with PAD, coronary artery disease, the common factors are usually diabetes and hypertension. So imagine if we can do that, it will go a long ways. Yes, we don't want to be doing, in our society, be it in rural America or in Africa, patients are always going to present with advanced disease. Yes, we want to treat those, but if we treat them or prevent them from having the problem in the first place, it will definitely be dollars well spent. Totally agree with you. Thank you for your question and comment. All right. Dr. Gupta, any more questions?
No more questions from the audience.
All right. So we'll move to our next presenter. Dr. Gupta, who's our next presenter?
It's a medical student, third year, rotating with you.
Okay, very well. Let me introduce him. Dr. Mehdi Sharma is a third-year medical student that's working with me at this time. I train medical student residents, and I find it fascinating that we should always engage and train our young ones because they are the future of medicine and surgery. So an opportunity to mentor them will help. I had the pleasure also recently, this past week, of speaking with one of my mentors, who I spoke with about a year ago. And he retired when he was 64, just like 33 years ago, and found out he's like 97. I called him and answered, got a call that he just played 9 rounds of golf, at 97. So, and he was my mentor, Dr. Addison Barber. He was the one that said, "Herb, relax, I'll make you a vascular surgeon." This was in 1990, 91, 92. So again, it's a pleasure to have medical students be part of this process so they can be prepared for residency. They can be prepared for life after medical school. Dr. Mehdi Sharma will be talking to us shortly. He'll introduce this topic. Thank you. Can you make sure it's sharing the screen?
Yeah. Right.
Are you having any trouble, Dr. Sharma?
Yeah.
No, we're just trying to figure out his screen share was working well.
We're just trying to make sure you guys can see the PowerPoint.
Yeah, that's it. Share your screen. This is, here you go. Oh, actually, this is better. Now you can just turn it up big.
Okay. Yeah, hello everyone. My name is Mehdi Sharma, or Mehdi Sharma for short, and I'm a third-year medical student, and I'm currently doing my rotation under Dr. Oye, and it's been a pleasure, and getting this opportunity to present in front of everyone, and Yeah, I'll be doing my presentation on postpartum hemorrhage in Africa, the incidence of postpartum hemorrhage in Africa. So let's get started. And so what is
you may want to put it on slideshow so that your full slide screen will show.
Slideshow. You did something, right? What did you end the slideshow? Okay, and then slide no. Okay.
On the top where it says slideshow, further, yeah.
Oh yeah. So try it.
No, now on the bottom, just click from current slide on the top left. Yes, ma'am.
Just
I guess it's okay. Yeah, for time purpose.
guess we'll just do it this way.
Yeah, okay.
So starting so what is postpartum hemorrhage? It's it's when a female after delivery, after the delivery process, when the baby has obviously come out and it's been delivered, they have a problem where there's heavy bleeding after giving birth. It's percentage wise, it's a rare condition, but it's extremely serious. As you can imagine, the hemorrhage severe hemorrhage can lead to shock and even death of the mother. So it's a leading cause of maternal mortality. So when does it happen? It typically happens within 1 day of birth, but it can also happen up to 12 weeks after having the baby. So these are classified as primary and secondary causes of postpartum hemorrhage. Primary being within the first 24 hours after birth, and secondary being after the 24 hours and before 12 weeks. So again, the primary versus secondary, and here we have a chart showing the incidence breakdown in cesarean deliveries versus vaginal delivery of postpartum hemorrhage. So if we just look at the end over here, it's 17% of scheduled cesarean deliveries result in postpartum hemorrhage, and about 13% of unscheduled deliveries result in postpartum hemorrhage.
oh, it's not changing there. Over here. Let's check if it's changing there. No.
We're just having an issue with the presentation not showing
Here in person on the projector.
on the projector, so I'm just gonna fix that.
Okay, let's see.
Are you having trouble?
Yeah, over here
It's-
on the projector, it's not showing the slides that I'm seeing on my computer. Are you guys seeing? Are
I'm
you
seeing
seeing?
you on slide 4 classification.
Okay.
Yeah, but it's for the projector.
They're seeing it.
They're seeing it. Okay.
Okay. All right. Okay. Yeah. Sorry about. So yeah. Like I said, 17.82% of cesarean deliveries generally result in postpartum hemorrhage. Most of these cases will be controlled with the techniques that I'll be talking about later that are used to control the hemorrhage. But yeah, so these are the numbers. And so looking at vaginal deliveries, about 55.56% of induced vaginal deliveries result in postpartum hemorrhage. So it's a big number. And then what can postpartum hemorrhage result in? So what can that lead to? So we start with the minimal, which is hypotension. It can just cause hypotension, which can then worsen into hypovolemic shock, and then the worst outcome will be ultimately death. What are some of the causes of postpartum hemorrhage? And starting with uterine atonia, which is when the uterus fails to contract after birth, and so when it doesn't contract, the vascularized uterus will continue to bleed because of failure of the contraction. Other causes are genital tract lacerations, retained placenta when the placenta doesn't come out fully, uterine inversion, abnormal placentation, where the placenta abnormally implants into the area of the uterus where it's not normally found. And last will be inherited coagulation disorder, which is genetic. Some of the risk factors that can be identified beforehand that cause postpartum hemorrhages are over distension of the uterus, which can be caused by multiple gestations, meaning twins or triplets. And further, it's prolonged labor or arrested labor. So with prolonged labor, the uterine gets musculature gets exhausted, and at the end, it's not able to contract and keep the blood from hemorrhaging. Infection and gestational hypertension and preeclampsia are also some of the risk factors that can be identified beforehand that are risk factors for postpartum hemorrhage. And placental abruption is the most common cause of painful third trimester bleeding. That's painful, and placental previa is most common painless cause of bleeding in the third trimester. Painless, sorry. So what are the some of the treatment options that we have? We can start with some of the interventions on the right side, which are non-pharmacologic, and starting with just the basic, which is bimanual uterine massage. So we try to control the hemorrhage with just manual massage of the uterus. Moving on, we can do things known as compression techniques. After which, and then we can move on to the pharmacologic. We will give some oxytocin to try to get the uterus to contract, because it's not naturally, that has not happened if there's uterine atonia. If the oxytocin is not enough, we move on to misoprostol and ergot alkaloids, which also contract the uterus and try to control the bleeding. And on the side, we will also give transfusions if the hemoglobin drops below 7 milligrams per deciliters. And then if all of that fails, ultimately our last options will be either uterine artery ligation or hysterectomy. And also Dr. Oye also brought up a technique where what we can do to try to control the bleeding is a balloon angioplasty of the aorta at periodic times. So we basically try to cut the blood supply to the uterus. So that's another way as well. That's more from the vascular side of things. Now moving on to the incidence of postpartum hemorrhage in Africa. Postpartum hemorrhage in Africa, according to an article in Elsevier and Science Direct, the incidence of postpartum hemorrhage in local women was 12.34 or 621 out of 5,011 women had postpartum hemorrhages, which is close to some of the numbers that we saw before. And uterine A20 was the most potent predictor of postpartum hemorrhage, as 32 out of 36 cases of postpartum hemorrhage were from uterine A20 itself. In another original article, Mozambique has one of the world, according to the World Health Organization, Mozambique has one of the highest birth rates in the world and has the highest maternal mortality, which is around 500 to 999 per 100,000 live births, and in death of the mother, and a large percentage of that is attributed to postpartum hemorrhaging and inadequate control of that as well. Some challenges managing postpartum hemorrhages in Africa is limited access to skilled birth attendants. So just skilled staff, limited access to that. Lack of resources such as uterotonic drugs and blood transfusion services. Cultural factors affecting healthcare seeking behavior, meaning people not wanting doctors and stuff to interfere with their natural birth process and stuff like that. And also poor infrastructure and transportation, where if let's say if they're going for a home birth or stuff like that, they're not able to get the transportation in time if a complication does occur in time. So some strategies for improvement will be antenatal care, in which we identify some of the risk factors that women have that we talked about before, that they're at risk for postpartum hemorrhage. So identifying that before it ever before delivery is planned, and education and training of healthcare providers, essential medications and supplies for the medical staff, and emergency obstetric care services, and community-based interventions where we promote birth preparedness and readiness for complications. And these are my references, and that's everything. Thank you very much.
Thank you. Any questions? Any questions for Dr. Sharma, please?
Yes, I have a question. My name is Sarah Toussaint. I'm a medical student, 4th year. Thank you very much for your presentation. This was a very interesting topic. And I do have a question regarding, is there any ongoing research initiatives or global health campaigns aimed at reducing the burden of postpartum hemorrhage in Africa that you came across?
Yeah. Is there any ongoing research on reducing the burden of postpartum hemorrhage in Africa? Is a question.
As far as I'm aware of, I'm not aware of any research, but I do know it's an issue, and it's been being talked about, but I'm not sure if there's any science focused research that's a prevention program like that. So I'm not aware of that.
The World Health Organization obviously has had this in their purview for a long time, because it's something that has been written up, and it's also in the literature as doctors presented. However, for things like this to get better, the government has to play its role. Many of these countries do not put enough monies in their healthcare budget to minimize some of this risk we're talking about. One of the ways, innovative ways of reducing this would be with that technique Dr. mentioned in passing, the balloon angioplasty technique. Imagine if we have a way of training young medical attendants, OB/GYN attendings, on how to immediately insert a little catheter into the femoral artery and put a balloon in the aorta, and inflate balloon. when the patient's having so much bleeding, they automatically can minimize the blood loss from that alone and deflate the catheter every 15 minutes. That'll give them an opportunity to figure out where the bleeding is coming from and control the bleeding. So that is something that I think could be a practical way of dealing with the problem. And the study that was done in Scandinavian country did demonstrate that successfully. So our goal as part of this ground rounds and foundations and stuff would be to see how we can make that a more practical way for us to improve healthcare PPH issues in Africa. So it's something that we certainly would like to look into. Thank you for your question.
Thank you so much.
Dr. Shang, yeah, thank you. Dr. Shang wants to make a comment. Go ahead, Dr. Shang.
Thank you. Dr. Ryan, you did a good job. A couple of questions and comments. You said that in Africa, the incidence is about, the prevalence of incidence maybe is about 12% plus.
Yes.
Compared with US, what is the percentage in US?
It's 3% in US, around 2.3%.
About 2.3%.
That is a lot. So just to let you know, the organization that is helping us together with this program, one of the things we're developing is maternal and child health in Africa, with emphasis on this kind of problem, postpartum hemorrhage. And in addition to the balloon that balloon angioplasty that Dr. Oye is mentioning, there's also a simple intrauterine silicone balloon that tamponade the inside of the uterus and start the bleeding. So that's a lot cheaper and easy to do than start for in the rural area. So this is one of the things Zuma is going to be focusing on. We kind of deviate from there for now, but it's going to be the next project we're going to do to focus on maternal health. So this is very appropriate time. Thank you. Thank you.
For those in the audience who may have not heard Dr. Shangade make his point, he was saying that the Zuma Foundation was working as part of this project on ways to improve maternal and infant mortality rates are quite high. And part of this concern with PPH would be to find innovative ways to help. And the Zuma Foundation will be looking into that too, along with other interested parties. Okay, thank you very much. Our next presenter will be coming to us from Baltimore, Maryland. And she is Dr.Toyin Opesanmi. She is a family care specialist and HIV specialist and addiction medicine specialist. Dr. Tony, are you ready for your presentation?
Yes, I am. And good morning.
Good morning, Doctor. Thank you for joining us today on this platform. I appreciate it.
Thank you. Thank you for including me.
Thank you. The floor is yours.
Yadi, can you give me co-host, please? You said you disabled the sharing.
I'm not the host, Dr. Oye is, but it should
make you. I'll make Yadi the host right now.
I can't share my screen, so you have to make me co-host.
Oh, on the bottom, Zainab, where it says share screen, just click that and say allow all participants to share screen so that the phone.
Okay, I did that.
Okay.
Thank you.
Thank you.
Thank you, Yadi.
Are you able to share it now, Dr. O?
Yeah, it looks like it.
Okay.
Oh, perfect.
Are you able to see?
Yes, ma'am.
Okay. And I'm trying to do slideshow and it's not working also. So
maybe on the begin where it says from current slide, you could try clicking that right above there, to the left of that. Yeah, right under. Oh.
There you go.
Yes.
Thank you. Good morning, everyone. And thank you for inviting me again. And I'm going to be presenting on diabetes mellitus. So I'm trying to position things so I can go to next. Yadi, you have to help me with this also.
Yes. Oh, just
There
your
you go.
arrow
I see
on
it.
your.
I see it. Next. Okay. So I'm going to start my presentation with presenting a precious patient of mine who, when I met him, it will be 6 years this year, but we parted ways last year. For reasons you'll find out later. He was 67 years old, African-American man, who came in with a history of diabetes and hypertension that he had not been able to manage for 10 years. He had complaints of poor vision, and his last eye exam was 2 years before we met. He had numbness and tingling in his feet, and his BMI was 42.45, which puts him in the morbid obesity range. His blood pressure was not well controlled. It was 168/100, and he just did not have a grasp of diabetes. So we had a lot of education to do, but his past medical history was not significant in terms of diabetes. He had kidney stones in 2013, no surgical history. His family history is significant for his father, who had diabetes, but no other person in his immediate family. His medications at that time was metformin that on the bottle he brought was 1,000 milligrams that it should have been taken twice a day, but he was taking one at night. He was on Farxiga and glipizide for his diabetes, and was on lisinopril, hydrochlorothiazide, metoprolol, and nisoldipine for his blood pressure. And you can see what his blood pressure was, very elevated on 4 blood pressure medications. So he was re-educated that his metformin was twice a day. He was encouraged to be adherent to his medication and medical care, and he was started on Lyrica for his neuropathy. He was referred to ophthalmologists and podiatrists, and we discussed lifestyle changes extensively. Thank you, Dr. Finn, because lifestyle changes is key, and we will talk a little bit more about that later. We also encourage adherence to his care. His labs showed that his fasting blood sugar was 273, A1C was 11.2. His LDL was 128, which was not at goal. In somebody with diabetes, it needs to be 70 or less. And he was, of course, spilling urine. Spilling glucose in his urine with 3+ glycosuria. So his medications at that time were continued, and statin was added to for his diabetes control. Again, lifestyle changes, losing weight, especially in his abdominal area, which was huge, and stopping things like sodas and chips and all of that were discussed, and we hoped for the best. He was also encouraged to check his blood sugars at home. He brought his Libre, which most patients don't have access to. He had it for a year, but didn't know how to use it. We taught him how to do that. His wife was present, and she attested to the fact that she is very, very non-compliant. So over a period of time, his blood sugars ran within the 290s to 350s. We just were not getting anywhere until one day he texted me a picture. And, when Dr. Oye was showing the picture of the wound, it reminded me of the picture he sent. And I'm sorry, I could have uploaded that to show that to you. But he had an open wound in the plantar aspect of his foot and didn't even know he had it. Most diabetic patients would not feel pain. They won't know that they have a wound. That's why we recommend that they check their feet, every day to make sure that they catch wounds if they have it quickly enough. His wife saw blood on the ground, on the floor, and they investigated it. Was how they found that he had a wound in the plantar aspect. It was started on antibiotics and referred to, podiatrists, endocrinologists also for, maybe better control of blood sugar to see if someone else educating him would help. Didn't help. Endocrinologists, I think, added Basagla to his regimen, but he ended up losing the fourth toe in the left foot and came back to clinic with complaint of 8 out of 10 pain, not responding to pain medications given to him. So we continued education on adherence, referred him to nutritionists. Then eventually he developed fatty liver, cirrhosis of the liver, ascites, had multiple paracentesis, and then developed open wound again on that left foot in the heel area, which eventually led to a BKA. He got amputated, got prosthesis that he never used because he then developed open wound in the right leg that was good before and was advised not to put pressure on that leg. That wound needed to heal, and so was never able to use the prosthesis. And unfortunately, this patient died last year. Was why, I said earlier that we parted ways, last year. This is an unfortunate story. And in our culture, something that, apart from lifestyle changes that we encounter, that is something we battle against, is the spiritualizing of diagnosis. Patients will tell me sometimes, it will not be my lot in Jesus' name. Oh no, I reject that in Jesus' name. And then maybe praying and not, taking counsel or medical care. And so that's an area where we have to work on in our African community. Well, diabetes is a chronic disease, as we all know, and it occurs when the pancreas does not produce enough insulin, or when the body cannot effectively utilize the insulin that is being produced, and for whatever reason in the periphery. For instance, some people may have hyperthyroidism that would cause the patient not to be able to utilize the blood sugars, not to be able to break down the blood sugars, rather, not to be able to utilize insulin in the periphery. And people can, develop hyperglycemia and eventually diabetes from that. So what are the risk factors of diabetes? Genetics can be one. This patient has, his father had diabetes, but obesity is a huge one. He was morbidly obese and was never able to reduce his weight. In fact, interesting story, true story. After his BKA and he was discharged home, his family had removed all sodas, junk food, and all of that. He got in his wheelchair and he wheeled himself to, I think it was one of those roadside, gas stations where they sell junk, chips and stuff like that, sodas. He wheeled himself there, and it took him 2 hours to wheel himself there. They were calling, looking for him, and wheeled himself back 2 hours to get sodas. So he never, really took his health seriously and never controlled his weight. Diabetes is huge. Diet, as I've mentioned, alcohol is another thing, and sedentary lifestyle, lack of exercise. These days, when a lot of people work from home, it's become even more of a problem for people to get up and exercise. So, we are recommending that, if you work from home, maybe every hour, get up and walk around, even in your house, and maybe schedule a time that you can actually go out and walk for 30 minutes a day, in the fresh air. It's very important. Some medications also can predispose to diabetes, like steroids, chemotherapy, some herbs also. A lot of people are big on these herbs lately, but we don't know the interactions of herbs, side effects, and stuff like that, because more researches need to be done on them. So we need to educate our patients to be careful of these things. So I wanted to show this to show the prevalence of obesity and, diagnose diabetes amongst adults. And you can see, what had happened between, if you look at the obesity chart on the top and compare it to diabetes with the year 1994, 2000, 2015, you will see how obesity has incredibly increased in our populations and has correlated with the incidence of diabetes. It affects all races. The CDC and WHO have declared diabetes as a global epidemic. So we have type 1 diabetes, which is insulin resistant, and we see that usually in younger ages. We have type 2 diabetes, which is seen, it used to be seen more in adults, but now we're seeing type 2 diabetes in the pediatric population because of obesity. So lifestyle change needs to start from young. This has become a problem when type 2 diabetes is occurring in our younger folks. Then there's gestational diabetes, which we see in pregnant women. Some pregnant women would develop, diabetes or hyperglycemia that resolves most of the time actually after the birth of the baby. But statistics show that women who have gestational diabetes have the tendency later on in years to develop, diabetes. And then we have the type half, which is latent autoimmune diabetes of the adult. This is autoimmune diabetes that begin in adulthood. Usually when people develop this, they will not need insulin for at least 6 months. But, the autoimmune disease continues to destroy the islet cells, and, the pancreas would eventually stop making insulin and they would become, insulin dependent. Then the pre-diabetes, if you don't check the A1C, you will not know. It's important to, check A1C and not just the blood sugar. Sometimes people have normal fasting blood sugars repeatedly. And if A1C is not checked, they will not know that they actually have increased risk of diabetes. That's what I call it. I don't like the term pre-diabetes. I like increased risk of diabetes because most of the time it can be reversed through lifestyle changes. If somebody is obese, they know that they have, increased risk of diabetes. They lose weight, they can reverse it. And that's why I don't like the term pre-diabetes, but that again has become an epidemic. The main symptoms of diabetes are polyuria, polydipsia, polyphagia, blood vision in some people. Some people would have weight loss, fatigue. Some will have GI symptoms and even respiratory symptoms. In type 1 diabetes, they may smell of acetone. So if you look at this slide, you will see the blue symptoms are more common in type 1 diabetes. So people need to know their symptoms. Some, women may have, vaginal infections yeast infections usually. And some men would present with sexual problems. Some will present with just numbness and tingling in their hands and feet. And so it is important to know the symptoms so that we don't miss the diagnosis. So the global epidemic affects millions of people, as you can see in this slide. You know, almost or just under 1 billion people are living with diabetes worldwide. And it is projected that there will be an increase of 25% in these numbers by 2030 and an increase of 51% by 2045. This is a huge epidemic. When Dr. Oye presented presented the guy with diabetes that ended up getting amputated, the core issue is preventing diabetes, to prevent these vascular problems and save limbs, save lives. There are 2.3 million deaths that were attributed to diabetes in 2021. So this is a major issue, major crisis. And, if you look at this slide, you will see, the numbers of people affected by country: China, India, USA, Africa. Nigeria, 3.6%. I just don't believe that number. Good records are not kept sometimes in African countries, and so we underestimate what is really going on. From my experience in Nigeria, I believe we have a lot more people than this 3.6 reported. And this is the prevalence of risk factors for diabetes in Nigeria. Unhealthy diet is still number one. Again, lifestyle changes. Unfortunately, in Nigeria, as well as other African countries, diet has changed to simulate or emulate Western diet. Hormones, chemicals, and all of that are now reading in foods that didn't used to be. And so, that is complicating things. Older age, urban living. Again, urban living is attributed to this unhealthy diet, because people in the villages are more likely to eat, healthier than those in the urban cities. Physical inactivity, you'll be like, really, in Africa? Yes, especially in the affluent, or among the affluent people who have cars. They drive from their cars from one place to the other. They don't exercise. They live lifestyle like it's lived in the Western areas. And family history, as I mentioned before, and smoking also is another issue. Obesity, if you see right there in the middle, I wanted to address this last in this chat, because obesity is also a problem in African countries, which when I was growing up, it didn't used to be like that. So I'll leave that alone, but it is something that we need to address. Lifestyle needs to change across the board. And in the United States, the stats is that 1 in 5 people, about 38 million Americans, have diabetes, but 1 in 5 don't know it because they have not checked. And that's why knowing those symptoms are important, so that if one has those symptoms, they can get checked and see if they have diabetes. Actually, seeing a physician once a year is a good thing. So I'm going to skip some slides. Diabetes diagnosis rate by ethnicity in the United States, you will see the American Indians and Alaskan and Native Alaskans have the most incidence and prevalence of diabetes. Then Blacks come next, Hispanics, non-Hispanics, and then whites. So what are the complications of diabetes? You know, we talked about the coronary heart disease. Dr. Oye presented that. When he was presenting, I was smiling that he's presenting my, doing part of my presentation, nephropathy, even kidney failure, neuropathy, as he has shown us, stroke, retinopathy, peripheral vascular disease are all, possible complications of diabetes. And this is another slide just showing that. This shows, neuropathy in diabetes. You can see the healthy foot here, and you can see damaged vessels in here in a diabetic patient that is already experiencing complication. Vision, is a big one. The number one cause of blindness in the world today, no matter where you are, is still diabetes. And, I must say also that diabetes rivals war in amputation of limbs all over the world. Look at this vision. The normal vision is the one on the right. That guy, the grandfather, can see his granddaughter clearly. Somebody with diabetic retinopathy, see what the vision looks like on the left. It's not fun. This can be prevented just by treating the diabetes or preventing it. And most of the time it is preventable. Diabetic nephropathy, like I talked about. Now, I want to switch to the costs of diabetes globally. The cost is staggering. From 2015 and projected to 2040, the cost of treating is in billions already, and it doubles all over wherever you look at. So we need to do something. Cost of managing diabetes in Nigeria, look at this, in 2017, 4.5 billion. In Africa, 25 billion. India, 78 billion. And in China, 114 billion. Staggering. This echoes, similar. So, diabetes in African Americans. More than 2.8 million African Americans have diabetes. But see how many of those have been diagnosed? Only 1.8 million. So the others don't get to care until complications have started. It contributes to 25,000 deaths, amongst African Americans in the US in the early 1990s. That number has tripled. It was the 7th most common cause of death. African Americans with diabetes suffer more complications than other races, with, amputations, nephropathy, kidney failure, blindness, hospitalization, name it. African Americans get the worst. And, African Americans, all the same to me. And you can see that also in this graph. The red line on the top is African Americans. So managing diabetes. The management of diabetes has to be personalized. It has to be patient by patient. Like I told you, some patients will spiritualize their diagnosis. You need to meet them there and, convince them. Some would tolerate certain medications other than others. And it also depends on the type of diabetes that a patient has. So treatment is personalized and individualized. You have to also look at the convenience for the patient. If, for instance, in patients with type 2 diabetes, the recommendation is to start with oral medications. But if eventually they need insulin, you give it to them, and then train them how to give it, but can they do it? Convenience of, administering medication or being able to use it is very important. With every patient, no matter what or where, early diagnosis is key. In medicine, we do well preventing, but once it occurs, we do well catching it earlier. In primary care, we do well catching it earlier. So, and then we can intervene and, salvage things. We need to do more researches also, even in diabetes, to improve things. And hopefully we can get a cure. It's always still possible. And every time we treat in primary care, we always look for the simplest combination, the simplest way. Thank God for combination medications now that decreases medication burdens. We are very big on that, to look at that in the treatment of these patients. So in order to win the war against type 2 diabetes, again, healthy habits, lifestyle changes with good diet and exercising, educating our patients, educating the public on these things are very important. Catching patients when they have increased risk of diabetes before they develop diabetes and reversing that through lifestyle changes is also another way to win this war. And when it's necessary, if we can help it, it is what it is, then we treat with medications, appropriate medications. Diabetes is a global epidemic. It's a pandemic. It's becoming the bane of our existence. We need to better understand the disease. We have need for personal responsibility to this disease, and we have to combat it globally in order to curb it. So that's my presentation for today. Thank you very much.
Thank you. Does anyone have any questions? Oh, there's one question from Dr. Theodora Finn. You can unmute yourself and ask Dr. O your question.
I have two questions.
Yes, ma'am.
Yes, Dr. Finn. How are you?
Dr. O, how are you?
Doing well.
I always say that to a particular specialist, everything is that disease in his or her specialty. So I'm a sleep specialist. So I'm going to focus on obstructive sleep apnea, since you indicate the incidence of obesity, which is on the risk.
Yeah.
And the reason for my interest is that sleep apnea in itself leads to the whole oxidative stress and heightened inflammation and endothelial dysfunction, all of the things that increase your risk for atherosclerosis and therefore vascular disease.
Mm-hmm.
What is the primary care team doing in Africa in this particular area in bringing about that awareness? I know it's an area of real lack, at least in my country of origin, Ghana. I don't know, I know Nigeria and Ghana were trying to partner to set up a sleep foundation and all that, but I don't know the extent to which this has gone. My second question is really anecdotal.
Mm-hmm.
My other job is critical care, and increasingly, I see a lot of patients who end up with MIs, strokes, and they have normal LDL, normal HDL, normal cholesterol level, and we keep chasing this cholesterol thing. It's very anecdotal, and I'm not sure if I have all the answers to it, or I've even done enough research to look into it. But what has been your experience?
Excellent questions. Sleep apnea. In Africa, we have work to do. we're not addressing it or focusing on it or not even looking at it. As far as I know, we need to do a better job. You're right on the money, and it's going to take you, it's going to take all of us. And thank you for all you are doing already in Africa. Thank you. I can't help but say this. I'm normally very energetic. I'm sure Dr. Oye would hit me later and say, what is it? What's wrong with you today? I'm not going to lie to you. I'm drained today. And part of it is, or the reason why is because a very dear friend of mine, his brother committed suicide in Nigeria with lithium and olanzapine. The Lord used me to save him the first time he attempted suicide in 2001 in the US. And they took him to the hospital, caught him on time, still conscious, put him on dialysis to dialyze him because you can dialyze lithium out, but not olanzapine. But they kept taking out electricity. Electricity kept going out and the machine kept shutting down and he died. And I was still dealing with that. And I got a call yesterday morning. My mother-in-law died yesterday morning. She was in the hospital with sepsis and they ran out of oxygen and the nurse did not know. So, Dr. Finn, we have our work cut out for us. Sleep study, yes. We need equipments also. And we need a lot of things. We have excellent doctors in Africa, excellent. But we need tools. They need equipments that they need to work to perform. So I hope I answer your question there. We need work to be done there. As far as, you said you've seen people with strokes, right?
No, normal cholesterol.
With strokes, with normal cholesterol, normal
MIs.
Yes.
Normal cholesterol and
MIs with normal. So I have a personal experience with a patient of mine who had, the first time he had an MI, happened to be an African also. The first time he had an MI it was 29 or 30. Cholesterol was normal, LDL was normal, blood pressure was normal. Cardiologists could not find the reason why. Before he was 35, he had MI, I think 4 times. And I went crazy over this. He was put on statin, treating cholesterol that was not elevated, but low dose statin because they couldn't find, they don't know what's going on. They put him on ACE inhibitor, he didn't have high blood pressure, all these low dose, aspirin, and all of that. I had medical students that, rotate with me, and the 4th time he had the MI, I said, look, homework, all of us, we need to investigate. Cardiologists don't know what's going on. Guess what we found? His homocysteine level was low. And I just started him on B1. He's been on B1 for years. He has not had another MI. So I don't know. More research needs to be done there. We continued everything the cardiologist put him on, and we just, left him on B1, and he's doing fantastic. The last MI, I think, was maybe 7 years ago.
Wow.
Yeah.
Interesting. Thank you very much. Thank you so much. And again, for interesting talk, doctor. And thank you for all the information on diabetes. We appreciate the input, and we look forward to talking to you some more. And I'm very sorry about your loss this weekend on your friend and your mother-in-law. So we'll talk to you off channel, off platform. Thank you so much, doctor.
Thank you. Thank you for inviting me.
Indeed. Thank you so much. Yeah. Okay.
And thank you, Yadi.
Yeah. Thank you. Thank you so much.
Phenomenal.
Anytime.
Thank you so much for everything. I
Yes,
appreciate it.
anytime.
Thank you.
Yes.
All right, very well. Dr. Yati, do we have the other doctor ready to present or no?
Yes.
Okay, let's have her present. Dr. Shangri will introduce. Thank you, Dr. Shangri. That's the one.
Okay. Very interesting topic so far. I have a young woman that is going to be our next speaker. I met her in Gambia. She is a very intelligent young lady. She has a PhD in pharmacy, and she's one of the big pharmacists in Maryland, trying to figure out what hospital that is. And she's going to be giving us a talk on some medication that we use in hypertension with focus on Black people. The reason for us inviting her to give this lecture is because Uzuma is working on a pilot project in Gambia to kind of basically diagnose hypertension and treat people with hypertension. It's a very interesting project that I'm helping out to write up the detail. And we are hoping that sometime this year we will go back to Gambia and get this program started. So the doctor that is going to give us presentation today was in Gambia with us for almost 10 days and knows all the ins and outs. So I'm glad to introduce Dr. Amarteokor. Thank you.
Hello, everyone. Good morning, good afternoon. I'm not sure where everyone is. Can you hear me?
Yes, we can.
Okay. All right. Yari, please share my slides.
Definitely. One moment.
Thank you.
Is that fine?
Yes, I can see it. Thank you. Dr. Olu, thanks for that introduction, and thanks for inviting me to be one of your speakers on this topic of hypertension. And as you stated, the emphasis being on Blacks, since we've been to the Gambia and we want to impart some healthcare services to help the folks out there. So in going forward, of course, I'm Naa Amarteokor Evans-Anfom Pharm. I have a Pharm.D, which is a Doctor of Pharmacy degree in clinical pharmacy. It's not exactly a PhD, but I just wanted to clarify that. Hypertension globally is a problem. In terms of being Black, I'd like to also clarify that Blacks are everywhere. So we have African Americans, we have Africans, we have Afro-Caribbean, and then, of course, we have folks who are mixed. So the melting pot is getting wider and broader. And so there's no actual limitation. But in terms of Africa, since he mentioned Gambia, of course, it will be totally Black. I've been practicing here in Maryland. So we have a mix of, all these ethnic groups and races. So briefly, though, I'll be just touching on an overview of what hypertension is, the epidemiology, risk factors, causes, lab work, diagnostic screening, and then treatment options, which one has to also factor comorbidities. Next slide, please. So in general, what is hypertension? I say that because sometimes it feels like we're just treating the numbers rather than the condition. So is it a condition? Is it a disease? Is it just numbers that we're chasing? Because we all know that it presents itself maybe 5 or 10 years later. There might be symptoms. Symptoms are not specific, and patients or individuals might overlook them and think it's something else. And then coupled with the fact that not everybody really goes to the hospital on a regular basis. especially if you don't have insurance. So screening is important to start in adulthood, that is 18 and beyond. So hypertension is also termed high blood pressure. And its definition or classification has been, I guess, cleared up or classified by the American College of Cardiology and the American Heart Association, where systolic blood pressure is greater or equal to 130 and diastolic greater or equal to 80. The recommended threshold should be below 130 over 80. And previously, before, the other entity that also provides clinical guidelines is the Joint National Commission. So coupled with, because we are global, the European Society of Hypertension and the International Society of Hypertension also provide their guidelines in collaboration with the World Health Organization. So these figures here in this slide show what the normal is. Normal would be below 120 over 80, between 120, above 120 to 129, and 80 to 84 would be considered normal. Anything beyond that has to be classified using the ACC/AHA guidelines or the European Society of Hypertension. Certain terminology, like one of the speakers talked about pre-diabetes. Pre-diabetes no longer is used. Pre-hypertension is no longer used. The term elevated blood pressure is more commonly used in practice now. And also, the diagnosis or incidence is much higher than because the screening is limited. So, for example, over the last 20 years, between 2009 to current, the world incidence has doubled, and the cost associated with that is also astronomical because of the damage it has to the heart, the arteries, kidney, the eyes, and other parts of the body. Next slide, please. Also, these are the condition affects multiple organ systems. So that is where the problem stems. And so catching it earlier and screening would help reduce these numbers. I'm not sure how it will be done. It'll take a lot of education, as one of my colleagues had said, with some of the other disease states. It's the leading cause of myocardial infarctions globally, and the lifetime risk increases. It's been found also to be more prevalent in Blacks and people of African origin. It's underdiagnosed, as I stated, and still termed the silent killer, because you only present with issues and then it's found that you have high blood pressure or hypertension. Blood pressure increases with age anyway. So they've actually classified greater than 140 over 80, 85 for older folks above age 60, 65. So depending on which classification scale you're using, you might find some variations. Basically, that's basically what it is. Like I said, African Americans, Blacks, people of African origin, and Hispanic Americans have a higher incidence than Asians and white or Caucasians. Next slide, please. So briefly, this states some of the blood pressure measurements, and it's of note that blood pressure taken in the office or at home may vary. And so the measurements and skills should be done in such a way that it is, you repeat it to make sure that this is what is going on, and you eliminate any possible causes, other disease states, or drugs that may even cause hypertension. In order to start treatment, they have to assess their cardiovascular or atherosclerotic cardiovascular risk evaluation using a scale that is available on many medical calculators. Next slide, please. So screening requires appropriate blood pressure measuring techniques, like I said, comparing home versus office. And typically, if it's on an outpatient basis, the ambulatory 24-hour monitoring is considered ideal, because this is the patient in their day-to-day life living, and you can figure out what the average is. And then you can also have to determine whether there's any end organ involvement, which will determine what treatment options you have. The different types are primary and secondary. The primary is a known cause. It could be hereditary, so medical history, physical exams, baseline labs are helpful. So if somebody starts their hospital or healthcare at 18, and this progresses and shows up later, at least there's a baseline which one can compare with. And hopefully there's no, other end organ associated with the high blood pressure or hypertension. Some of the other causes are sleep apnea, drug-induced, like chronic diseases like kidney failure, although this will also cause kidney failure, and a few others that we wouldn't be discussing in this scope. Next slide, please. Next, please. So, like I said earlier, the treatments depend on the guidelines, which are based on several studies that have proven and show evidence that treatment helps. Now, anybody who is on treatment and still is controlled is still considered hypertensive. So a lot of people tend to think that, well, if I'm on medication and my blood pressure is controlled, then I'm no longer hypertensive. But that's one, teaching that we have to show our patients, that they need to, this is going to be a lifetime thing, unless we identify what the causes are and can work on the causes. But most people just want a quick fix. And like I previously said, this disease is ongoing and would have precipitated and started much earlier than when it is diagnosed. Next slide, please. So here again is the risk factors that are associated. So in addition to investigations or labs, this calculator will determine your threshold and your goal. And I think below 5% is considered normal. And so that is a borderline. If your patient falls right there, then they need to be screened more frequently. Next slide. This shows an algorithm as to how the condition affects the different parts of the body. It's mainly the afterload, which is the heart pumping the blood and increasing the pressure. as well as the preload, and then the heart itself pumping and the contractility of the heart. So heart rate, stroke volume, cardiac output, and all of that play a role in that. So specifically for Blacks, the choice of drugs is based on the fact that we are supposed to be sodium sensitive, so that the disease projection or the cause is stemmed from the fact that we retain a lot more sodium. So in treating, that is a factor that we have to consider. And that also comes with potassium and sodium and calcium as well, and the function of the kidney. So if we, as people without hypertension, already have these things against us, high sodium and sensitivity, it's already affecting the kidney and the kidney function. And then the hypertension also comes and adds on. So it puts us at more risk. Next slide. Yeah, this is also the different aspects of hypertension and the different ultimate effects that could happen, lead to heart failure, MIs, retinopathy, stroke, and more. So we can go to the next slide. So in treating, as everybody else is treating, the non-pharmacologic interventions are key. And it's very difficult to follow up on patients because most of it are I guess, imposed. There's nobody to be there to check on you. You can I recommend them to have a journal and you review it. But this involves a team of, healthcare practitioners. It's a multidisciplinary mode of teaching the patient what it is. Education is key. And we have to get a buy-in for the patient, because you can list everything, but once they leave your office or the hospital or the urgent care, we don't know what happens really. So to run through these, lifestyle modifications are very important. And these interventions have been shown to, reduce blood pressure up to maybe even 20/10 in some cases, like weight loss. So diet also, using the DASH, which is the dietary approaches to stop hypertension, works a lot better for us Blacks because of the salt content in our foods. Encourage diets, well-balanced nutrition. So seeing a nutritionist and referring them to a nutritionist or a dietitian also helps. Because of the progression of the disease, seeing the ophthalmologist and podiatrist also is recommended. Smoking cessation. Smoking has been known to affect, the arteries and the integrity of them, which will affect the pressure in them. Identifying root causes such as, stresses, really. Doctor who spoke before me talked about urban and rural areas. In Africa, they found a difference in hypertension in people who are in the village and those who are in the urban areas. So that's also key, trying to identify what the causation is. But trying to maintain ideal body weight. A kilogram loss is equivalent to 1 blood pressure reading drop. Alcohol consumption has also been known to affect blood pressure. And so adherence is key. And like I said, that is a difficult thing and we need to empower the patient and include them in decision-making, especially their caregivers, if any. Next slide, please. This again is another algorithm or drug treatment. And the first line of drugs are the diuretics. Actually, the listed drugs here are in general for everybody. Diuretics, beta blockers, ACE inhibitors, calcium channel blockers, the ARBs, and alpha receptors. Some of them are basically for hypertensive emergencies or urgencies, which we'll not be discussing at this time. Next slide, please. So the first line of drugs are the diuretics, the ACE inhibitors, calcium channel blockers, and the ARBs. So for Blacks, the first line is thiazide diuretics because of the sodium sensitivity again, and calcium channel blockers, as compared to an ACE or an ARB. Those can be used as well. And one can start with one drug and add another. And the second would be the calcium channel blockers. And these also come in combinations. So for adherence, for example, it'll be better to give a patient the combination drug rather than individual ones to reduce the pill load that they will take. So on here are the different modes of action, which, if you're all willing to get this slide, if you want to read more. Next slide, please. Second line of drugs include the non-thiazide diuretics, like the loop diuretic, furosemide, direct renin inhibitors, alpha-1 blockers, central alpha-2 agonists, and then the direct vasodilators. Most of these are used, like I said, in the ER setting with hypertensive crisis or emergencies. And once again, the threshold and the goals of treatment is dependent on other comorbidities that exist. So this is included in the diagnostic and the screening process at the time. Next slide, please. So yeah, a few takeaway notes that I came across, or I managed to summarize because of time. Once again, for Blacks, African Americans, people of African origin, first-line agents are the thiazide diuretics and the calcium channel blockers. But note that this should not preclude trying any others, because like I said, most of us Africans have, multiple ethnicities and race. And so our genetic predisposition is a mix. So if one doesn't work, you add another and you max out the dosage and then add another. And then if it's resistant, you have to go back and find out what could be the cause of it. Pregnancy issues like preeclampsia, as they mentioned earlier, those also exist, and they have they usually use the labetalol, nifedipine, and methyl-dopa. Most of all the guidelines and the treatment algorithms are based on the American Cardiology guidelines and the American Heart Association. But like I said, being that this is a global forum, one would consider the WHO recommendations plus the European Society of Hypertension, as well as the International Society of Hypertension guidelines. Of note, I didn't see too many specific studies related to women, but I'm sure, there are a few more than there were when, 20 years ago, 30 years ago. So, and also women's symptoms are different. So that's another concern too. So in a nutshell, screening must start around 18 once somebody gets into adulthood. moving from pediatrics to adulthood, it's recommended get enough baseline information so that as these changes occur with one's medical history and family history and all that, one can determine if there's any change. The non-pharmacological treatments must start in the elevated stage if one notices the change occurring, rather than wait till you're in hypertensive state and then work back. The treatment goal is to maintain less than 130/80. Resistant hypertension occurs, and as I said, work up again and look for underlying causes. And then one thing I didn't mention or touch on is drug-drug interactions. So that is also key. And now with the advent of pharmacogenomics, some drugs are metabolized or broken down or become effective or non-effective based on one's gene. So that is also becoming part of clinical practice and probably will become a mainstay where everybody has their own pharmacogenomic testing, so that if a drug is to be chosen, one would also look at that in addition to comorbidities, family history, presentation, symptoms, and all of that as the lab work and investigation. Previous doctor, also Zainab, or the other, she also mentioned the spiritual aspect of Africans and Blacks in our disease states and all of that. So now there's functional medicine, Ayurvedic medicine, everything, and the complementary alternative medicine, which is good because most drugs do stem, from plants. And so that is something that we must also, when we're taking our MedRec and reconciling a patient's medications, to find out what supplements they are taking. Are they taking any traditional medicines? And in Africa and Ghana, I know that is prevalent. And I think that may be contributing to a lot of the renal failure and dialysis issues that we are having, because there's no monitoring of it. And the medication or the supplements and concoctions they are using are not necessarily measured. And some people think to take more will yield a better result, but then it makes things worse. So overall, patients whose blood pressure is controlled, like I said, are still diagnosed, indicated as being hypertensive. So I hope that I shed extra light on what you know about hypertension. And as I do here, a few references that I was able to gather all this summary from. And like I said, these slides are available if you would like to have them. Thank you again for this opportunity.
Thank you, Dr. Amarteokor. Thank you so much for the comprehensive talk on hypertension in Blacks and people of African descent. I appreciate your talk. One of the things I see when I travel is you are talking to somebody across the table and they're common cold, and you check their blood pressure is 250/150. And you kind of worry, 250/150, it's a common practice. You go to Nigeria and see that all the time. So, and then these are people who are, they have no symptoms at all, just talking, and next week they have a stroke. And, so those are things that happen. So I suspect that controlling blood pressure should be a fundamental thing we should do across the board. If we do that, we know we can save or spare a lot of people, a lot of us, the anguish of having strokes, heart attacks, and PAD problems and the like. So yeah, so I think we need to come up as a pharmacist. I think we need to come up with creative ideas on how to make blood pressure checks easily done, in the continent, in the subcontinent, whatever. So that way people would know they're hypertensive or not, and then do the best way to get them treated if possible. So that's something I think we all collectively work on. It's a major problem. And it's a problem that we see in the US. So it's not like it's something unique to Africa. And imagine if you control your blood pressure, you can avoid kidney disease, you can avoid strokes, heart attacks. It's just way too many. And then if you add diabetes to the mix, it's even worse. So between blood pressure and diabetes, most of our problems may be solved. Take away cancer, Thank you for the talk. And Dr. Shangade has a question for you.
Well, it's not so much a question. Thank you, Dr. Amarteokor, for teaching me the difference between D Pharm and PhD Pharm. So now I know the difference. So you are Pharm.D, right?
Yes.
Good. Dr. Oye used to be a pharmacist, so he already corrected me too. So I know the reason now. But I have so many comments to make, but we don't have time. So I'm just going to make a few comments. One, I have to thank Dr. Gupta and my young lady that is on the board of director of Ozuma that is also helping Dr. Gupta in this process. Her name is Amy. She's first year student in Duke University, and we're always very proud of her. She was on one of those TED Talks about a year ago. So hopefully one of these days you can listen to Amy on the TED Talk. But my main comment is about, if you see everything that is presented today, it will confirm the fact that 70%, I'm going to repeat myself, 70% of all the diseases we have in this world is all related to lifestyle, period. Only very few percentage is related to genetics. Even the intrauterine and the postpartum hemorrhage could be called lifestyle changes. If you have a woman that has 10 children, her uterus is going to be atonic, and we definitely have postpartum. So that's our lifestyle. Everything, hypertension, diabetes, OSA, everything. So obesity, lifestyle, okay? Personally, I do have high blood pressure, and that's because I used to be 30 pounds overweight. Now I'm down to 10 pounds overweight, and it's difficult to lose that. I'm going to consult you after this meeting to see what medicine I should be taking, but I am on that side as part of my 3 medicine stop. But I know there are special medicine that is best for the Black population, so we have to emphasize that. So I thank you for giving us an insight into how to treat it. So we are very excited. The Zuma is excited to start this project in Gambia. Hypertension is just common in Africa, just everywhere. Just like Dr. Oye said, you see some rich man in Lagos, and then they stroke out and you check their blood pressure is 250 over 150. It's so common. That's why they're dying young, and all these rich people are very lazy. They have about 5 maids, their belly is big, their neck is short, and they have sleep apnea and they don't know it. They don't know they have high blood pressure. They let somebody do everything for them. Sedentary lifestyle, no exercise. Most diseases is all lifestyle related, period. Thank you.
We have one question, one more question for you from Dr. O. You can unmute yourself, Dr. O, and ask.
Thank you. I think Dr. Finn also has a hand raised. So thank you so much for that excellent presentation. Thank you. You covered everything, and I'm very excited that you also mentioned the new research that is now guiding us in treating our African American Black people generally. The diuretics being the first line with calcium channel blockers, and also in older folks, actually. So what I wanted to say is that we need to encourage our patients to participate in research. The researches that were done in the past were done in white males, not even white women. And you're right, more researches need to be done in women, and also, regardless of color. We need to encourage our patients to participate. Otherwise, we will not know the the best way to treat. We will still continue to treat with what we know. It was the research that were recently, not too long done, that more Black people participated that led to us knowing that the ACE inhibitors, ARBs, are not necessarily the best thing for people of color. Then I wanted to mention also that in primary care, we actually start checking blood pressures way before age 18. It's very important. We diagnose high blood pressure in much younger people because of obesity. Things have changed. We're seeing type 2 diabetes in pediatric patients that we never used to see. That used to be type 1 that we will see in younger kids. Now we're seeing type 2 diabetes, we're seeing high blood pressure. So age is not a factor in starting, and screening for blood pressure anymore. We check them as young as possible. And I'm turning to Dr. Oye and Dr. Finn, checking blood pressure. If we go to Giant, Walmart, there are blood pressure monitoring devices that people will just sit and monitor and check their blood pressures. We need to look into doing things like that also back home. And Dr. Oye, you're right. We were together at, in Lagos at medical missions this last December. A patient walked in, or a participant, I'll say, walked in with blood pressure 247/175. Dr. Amma, I was stunned. I freaked out, and the young doctors there who we liaised with in Nigeria said, "Oh, it's okay." I said, "He's walking." He walked in to the medical missions. It was behaving normal. So we immediately changed the course of things, and we got the patients in the 200s/100s into the emergency department area and started education while we intervened with, medications right away. So we have work to do in Africa. Thank you so much. Appreciate your presentation.
You're welcome. Thank you.
Thank you. Dr. Fain has a question.
Amarteokor, thank you so much for your presentation.
Hi,
My question is actually to one of the participants that I see here. Professor York. Professor Ernest York is an endocrinologist at University of Ghana Medical School in Ghana. Professor York, I wanted to know your experience. And he is also, he's endocrine and of course deals with hypertension, etc. I wanted to know your experience from Ghana with respects to Ghana. Sorry for putting you on the spot, Professor York.
Is he unmuted?
He's still muted.
Yeah, so he won't hear.
He hears, he just needs to unmute.
Send him a message on chat.
Okay, I'll touch base with him.
Yeah, okay.
So, well, if I may say something to a gentleman who just spoke before me, when he said he lost 30 pounds and he needs to lose more, when you lose weight, no matter what modality you use, you get to a point where you plateau. We need to know what you did to lose weight so we can give you suggestions on things to introduce to continue to lose the weight. You will continue to lose it with lifestyle changes, but we have to know what you did to get to that 30 pounds, and then we can buck that plateau that you're in.
Don't eat for 10 years. Thank you so much. Let's get we got time pressed now, so I'll get our last presenter, my young Dr. Zainab Khan, to give her a quick presentation, and we'll wrap this up. Yeah, thank you, Doctor.
Here you go. Hello, everybody. I am Zainab Khan, a third-year medical student at Avalon University School of Medicine. It's very nice to be here, and thank you, Dr. Oye, for allowing me to present this. Just give me a second before I'm just trying to figure out my presentation. Here you go, I guess. If I just share my screen. This. I hope everybody is able to see.
Yes, we can see it.
Thank you. So, yeah, today my topic for presentation is revascularization of bilateral subclavian vein and superior vena cava occlusion, a case report. Before I go ahead with my presentation, I would really like to talk about the risk factors that can actually cause this stenosis or occlusion of the subclavian vein, or SVC. The risk factors are thoracic outlet syndrome, cancer, for example, lung or breast cancer, as you will see forward in this presentation, is that this patient had pacemaker placement or thrombosis. Let's just say that multiple bouts of DVTs or PEs, certain reoccurrences of cause can also lead to this case. Central venous line, access line, which we usually do in dialysis patient or sickle cell disease, trauma patients, or chest radiation therapy. Moving ahead, I was able to come across a study that was done at Mayo Clinic years ago, showing us the data and related to the multiple risk factors and their incidence of axillary venous occlusion. So this was a study done for a total of 95 patients, and here you can see that most of the patients that actually got this complication were because of they had effort thrombosis, thoracic outlet syndrome, central venous access line, and so forward, that we see that patients had trauma, drug-induced pacemaker implantation, tumors, intravenous injection of contrast medium, or progression of acute arterial thrombosis. Going ahead with my presentation, I would like to introduce to the case. This was a 76-year-old Caucasian female with a history of breast cancer leading to total mastectomy of the right breast. Preoperatively, the patient presented to the office with problems having edema, discomfort, pain in the arm, as well as mastatitis of the right breast, and also the surgical history. She had a medical history of DVTs. She has primary hypertension, GAD, and intervertebral disc herniation of cervical, thoracic, and lumbosacral. I have mentioned which were the medical diseases which were active for her currently. The surgical history that she had was right wrist surgery, brain aneurysm clamped, left foot surgery, pinched nerve, and Mediport insertion and removal. Family history, she had none. Social history, she is a formal alcohol user and a current everyday consumption of caffeine, as well as she is a smoker of 1 pack a day. The medication lists are below, and if you see that she has been taking amlodipine, Plavix, Eliquis, buspirone, tizanidine, robustatin, clonidine, PO, everything daily as per whatever diagnosis she has, and allergies were to sulfa drugs. So moving to the case report, we were able to give her anesthesia, moderate sedation with 2 milligrams worse and 4 milligrams of morphine. This is kind of a summary of the procedure that we performed. We did bilateral upper extremity venogram, bilateral subclavian venogram, angioplasty on the left and right subclavian vein with the help of 10 into 40 millimeter concus balloon, angioplasty of the right basalic vein with the help of 8 into 40 millimeter concus balloon. And the findings on the venogram that we saw were prominent chest wall collaterals, bilaterally replacing completely her superior vena cava. These are the pictures. Here you can see this is the right arm, and you can see this is the collaterals that they were developed in the chest wall. And here on the left side, you can see as well that it was the same. Following the venogram, we moved ahead with 24 gauge angiocat placed both in her wrist, and we allowed a low osmolarity contrast to demonstrate the flow through the basalic vein and cephalic vein. System on the left showing the occlusion of the subclavian vein and axillary vein junction. And superior vena cava was occluded with prominent chest wall collaterals on the left as well. As we saw in the last slide, the collaterals were developed on both of her chest wall. It wasn't just on one side of her body. Venogram of the right upper extremity showing a significant disease of axillary vein and cephalic vein. Then we proceeded the procedure with cannulation of the right basalic vein using a real-time ultrasound. Microvenous guide wire and sheath was introduced, and we upsized it subsequently as per it was needed. So we started with a 0.05-inch guide wire with the 4 French sheath, and then we subsequently increased the size to 6 French and then 10 French. Venogram performed to confirm occlusion of the superior vena cava and subclavian veins bilaterally. With the help of advantage wire as the NSDR catheter manipulated across the area of occlusion, balloon angioplasty was performed with Conquest balloons, and we adjusted the size as needed. We used the size 10 into 40 millimeter Conquest balloon to we took the pressure up to atmospheric pressure up to 8. Then we decreased the size to 8 into 40 millimeter Conquest balloon to treat the basalic vein on the right side. The completion of the venogram showed marked improvement in flow of the subclavian veins. The procedure terminated with stent placement on the right arm at the axillary vein segment, and the entry site was sutured with 3.30 Becquerel sutures. And then digital compression was applied, Curlex was applied, A-straps were applied to prevent any hematoma at the site of the suture. Here, I will like to show you, why is the video not loading? This one will, is this connected to internet? Should right. Let me try again. Let me try the other one first.
Yes.
Oh, so unfortunately, I'm not able to play the video here on the presentation, but we had the video for both the showing us the balloon angioplasty of the left arm and the right arm. This was for the right arm. In conclusion to this case report, we were able to see that unilateral arm swelling without thrombosis, when not caused by lymphatic obstruction, can be due to subclavian vein compression or occlusion. Also, the presentation the patient had of the inflammation of her breast can also be one of the signs that a patient has subclavian vein occlusion, and that was one of the interesting findings that I had during I found one of the researches that was recently done. And the bilateral chest collaterals that were seen in this patient pre-procedure venogram shows the abnormality and CTO of subclavian vein and SVC, as we discussed before. The main objective was that we did a minimally invasive percutaneous procedure, and it was ample to significantly achieve the improvement in the blood flow. During this vascular procedure, we were not only able to treat the right arm occlusion, but also was able to guide the same wire from the right arm towards the left arm, allowing us to perform the balloon angioplasty smoothly and efficiently. Here are some of the research references that I found related to this topic. I hope it helps. Thank you, everybody, for letting me speak.
Thank you, Dr. Khan. Thank you. That was a nice presentation, Dr. Khan. And again, this is, she had mentioned the key word, people that have, when you see as a clinician, you see a patient with swelling of the upper extremity, right or left, or facial swelling, first thing you should look for is if there's any evidence of veins that should not be there on the chest wall, on the chest area and the arm. If there are, you should strongly suspect that there's a proximal blockage or stenosis at some point, and that was the case here. Patient came in, we did not see the varicosities on the side of her chest until we did the venogram, but we did see varicosities on the front of her chest, which suggests that she may have a blockage. So it was very easily done, and she did well. She came to the office a week later, and her symptoms had resolved. And usually, if you do minimally invasive technology to treat patients like this, their symptoms should go away within 3 to 7 days, which is the case here. So thank you again for a nice, short presentation. Appreciate it. We're time pressed, so I will conclude by saying thank you again once more for the opportunity we've had to have your presence in this platform, both in person and virtual. Would like to thank the Zuma Foundation and its members and friends for joining the program today. Members of the Oye Global Medical Foundation, as well as the Edward B. Revascularization Society, as well as the Global Vision World Health Mission from Dr. Shangode. Would like to also thank all our speakers for honoring our invitation today and speaking on this very important topics on diabetes as well as hypertension. And we appreciate your work. I'd like to also thank our young doctors for joining us today and presenting as a focus for their career. This is the first step for them to continue to improve their educational standard. So we thank you very much. I'd like to take opportunity also to thank Dr. Gupta for the fine work she's done over the years. And we appreciate Dr. Gupta a whole lot as the program coordinator for the Global Ground Rounds, as well as the Endovascular Conference for Africa. In summary, take home message: diabetes and hypertension are major problems that we need to solve. Major problems here in America, in Europe, in Africa, of course. So whatever we can do to move the needle in a positive direction will be helpful. Please join hands with us through the Zuma Foundation or your Global Medical Foundation and other platforms to see if we can help make this happen. Thank you so much, and we look forward to seeing you on our next presentation in August of 2024, the third annual, the third version of our quarterly program. And hopefully also in October, we'll have the Endovascular Conference for Africa and Rural America. And we hope to see you then. Thank you so much. And I'll talk to you all later. Bye now. All right.
Thank you.
Thank
And
you.
if everybody can send me their emails, I posted my email in the chat. I'll send the survey out from Uzima Foundation based on today's meeting, and I can send you guys the recording of today's conference and keep you in the loop for future grand rounds and for the upcoming annual endovascular conference, which happens in the fall time. I put my email in the chat again, and I'll take the emails. And thank you for the people who shared it. And again, thank you so much, everybody, for your participation.
Thank you.
Thank you, Yati.
Thank you.
Thank you very much.
Weekend.
Thank you. And we got off right. Bye-bye.
Thank you all very much. Bye.
Thank you. Bye-bye.
Bye.
I can do is
Wait 1 minute before exiting it so I can just take the emails in the chat.
okay, sure.
Okay, you're good now. Thank you.
Thank you so much. Thank you for helping me
Of course, of course.
and for all the late night emails I sent you. Thank you.
All right. Have a good weekend.
You too. And I guess I just need to end.